All right, just when you thought, oh, we're happy we don't have to listen to that woman's voice again, I'm back for more. Promise, this is it for me. All right, so May and I will finish up this module with medications. So I know we've thrown out a lot of different names of medications, but commonly used to treat side effects and try to prevent infections in patients who have received CAR T-cell therapy. So I will start with a well-known player, dexamethasone. So this is a corticosteroid anti-inflammatory. And how it's used in the management of CAR T-cell toxicity is to decrease inflammation and the production of cytokines that results in systemic immunosuppression. They do cross the blood-brain barrier. So like I mentioned, this is the gold standard treatment for ICANS, but can also be used to treat CRS that is refractory to anti-cytokine therapy. So Dex is, again, one of those drugs that is used carefully in this patient population because there is the fear of destroying the genetically modified CARs that were infused. This is a long-acting corticosteroid, which does help to decrease inflammation, and it does suppress neutrophil migration, and the normal immune response. So again, we have this fine balance of treating these side effects without hopefully incurring a large infection for the patient or an infection that is hard to treat and results in a poor outcome. There is recommendation to avoid using dexamethasone in patients who are known to have active fungal infections, and tapering is required at the end of treatment. So a big patient education piece, if the patient is sent home on a dexamethasone taper, is they need to know their taper so that there is not an abrupt end to their drug. Dosing and administration in the CAR T-cell setting is considering treatment at grade 2 ICANS. Grade 3 ICANS treatment varies, but often in the literature, it's recommended that 10 milligrams every 6 to 8 hours is commonly used. So when the patient is experiencing grade 3 ICANS, it's pretty severe. And at that point, all providers want to prevent the patient from advancing to grade 4, which is cerebral edema and can be fatal in patients. Like I've said, the introduction of steroids can diminish the efficacy and the proliferation of the CAR T-cell therapy. There's also the other lovely, very well-known side effects of steroid therapy that include hyperglycemia, weight gain, increased risk of infection, GI upset. So oftentimes some type of prophylaxis with an H2 blocker or a PPI is recommended if a patient is taking steroids for a period of time. Patients can develop cataracts post-steroid therapy, as well as it increases the appetite. So if a patient does experience grade 4 ICANS, the treatment recommendation with steroids is actually methylprednisolone, 1,000 milligrams or 1 gram daily for 3 days to try to prevent irreversible damage from cerebral edema. Using steroids cautiously in the geriatric population due to the increased prevalence of psychosis in this patient population. There are multiple drug-drug interactions with dexamethasone, and adrenal suppression can result in long-term use of steroids. Next is tocilizumab. So this was originally approved as an anti-rheumatic. It was used treat juvenile rheumatoid arthritis. And when they treated some of the first patients with CAR T-cell therapy and this CRS massive inflammatory response occurred, there were a lot of question marks in the providers' minds of what do we do, what should we try? And tocilizumab is an interleukin-6 receptor antagonist. So an IL-6, which is one of the cytokines that is known to be circulating in high volume when patients experience CRS post-CAR T-cell therapy. So when tocilizumab puts a cap on the IL-6 receptor, it tamps down the inflammatory process and helps to decrease the circulating cytokines and mitigate the symptoms that the patient is experiencing. This can be used per the FDA approval for the treatment of CRS for patients greater than or equal to 2 years of age. It does not cross the blood-brain barrier, so it is used to treat CRS alone, not ICANS. It inhibits the production of IL-6 cytokine, and it does not impact the efficacy or the expansion of CAR T cells. So it's nice to treat the symptoms without having to worry about any impact on the CAR T cell efficacy. It is a monoclonal antibody, so it does increase the patient's risk of infection. So monitoring patients for signs and symptoms of infection is very important. Dosing is 8 milligrams per kilogram with a cap of 800 milligrams. Doses can be repeated. There has to be a minimum of 8 hours between each dose of tocilizumab, and the maximum is 4 doses. And the idea behind that is if the patient isn't responding, the symptoms aren't responding to tocilizumab, it's time to move on to a different treatment for their CRS. Some adverse effects from tocilizumab, because it is a monoclonal antibody, there is the potential for hypersensitivity reaction, and it can increase the patient's hepatic enzymes, cause constipation and neutropenia. There's a higher rate of infection in geriatric patients when they receive tocilizumab, lots of drug-drug interactions, and warnings and precautions. So like I spoke about latent viral reactivation as a potential in this patient population. If they are treated with tocilizumab for CRS, it does increase their risk of herpes simplex virus reactivation. It can cause hyperlipidemia and malignancy. It also is known to cause reactivation of latent tuberculosis in pediatric patients and can result in delayed wound healing. Levetiracetam, so this is the anticonvulsant or the anti-seizure therapy that can be used either as prophylaxis or treatment. Like I said, there are different approaches for prophylaxis for all patients, prophylaxis for patients who experience CRS with the potential to develop ICANS, or no prophylaxis until the patient develops some type of neurotoxicity symptoms. Patients who do have a history of seizures or CNS disease, there is advice that prophylaxis should be implemented when the patients receive CAR T cell therapy, because one of the signs or symptoms of ICANS can also be seizure activity. How this is used in the CAR T cell population is it does help with seizure prophylaxis or treatment for patients who have undergone CAR T cell therapy. It does have a favorable side effect profile and has limited drug-drug interactions. So if patients who are being treated with CAR T cell therapy also have polypharmacy, this is a better drug for them. The exact mechanism is unknown of this drug, but it has potentially one or more central pharmacological effects. Safety and efficacy, the one thing to be aware of is it should be renally adjusted based on the patient's renal function and if they have any type of acute kidney injury or renal dysfunction. And the advantage of this drug is there are both PO and IV dosing availability. So if the patient's ICANS is to a point where they are unable to safely swallow an oral agent, this can be ordered or converted to an IV formulation, which is as effective. Some adverse effects of levetiracetam can cause CNS depression. Patients can have hypersensitivity reactions, psychotic symptoms, and behavioral changes. That's a little bit challenging, especially if we're prophylaxing a patient who may be experiencing ICANS. There is a longer half-life in patients with decreased creatinine clearance who receive levetiracetam, multiple drug-drug interactions, and food may delay absorption, so it may be better administered on an empty stomach. And then again, dose adjusting patients with renal impairment, and then discontinue with a gradual decrease of dosing if it was used to treat seizures. So again, not stopping abruptly. All right, I will hand it over to May to continue our last few drugs to treat side effects of CAR T cell therapy.
Hello again. I have a couple of agents that I wanted to talk about in managing the CAR T toxicity. So a couple of them is anakinra and IVIG. So anakinra is the IL-1 receptor antagonist. It's actually FDA approved for subcutaneous injections for rheumatoid arthritis and also cryopyrin-associated periodic syndromes. And we have considered and we have used anakinra in the refractory CRS and ICANS. So in the setting of CAR T toxicity management, The guidelines actually recommends that third-line agents in the management of CRS that does not improve after 2 doses of tocilizumab and the steroids. But in my experience, we have not gone to anakinra that quickly. We will utilize the tocilizumab and steroids. However, we do use a anakinra for late onset HLH, mast pathology, and rationales for using anakinra and CAR-T toxicity is that we have a good data showing the critical roles for IL-1 signaling in the pathogenesis of ICANS and CRS that previous speaker has spoke about. And mode of actions is that it is the recombinant form of human like IL-1 receptor antagonist. It was produced by the recombinant DNA technologies using the E. coli bacteria expression system. So safety data, safety and efficacies generally is they have retrospective single center studies looking at 14 patients with axi-cells or T-cell cells for a steroid refractory ICANS with and without CRS. And there's a good response as the second lines, and there's a statistically significance in rapid reductions in fever, inflammatory cytokines, and biomarkers associated with ICANS and CRS after anakinra treatments. There are also retrospective multi-center studies showing that anakinra's treatments is feasible and is safe up to 12 milligram per kilogram per day IV with the limited impacts of anakinras on our CAR-T's efficacies. So high dose is considered greater than 200 milligram per kilogram IV. So for us, if we do use it for the HLH, that will utilize the high dose. Low dose is 100 to 200 milligram per day, sub-Qs or IV. In our facility, we may use some of the patients that have a higher disease burden. We may potentially use this as a prophylactics at the early on. One of the challenges, not necessarily challenges, but for our patients that are managed in the outpatients CAR-T infusions, if we do give prophylactics anakinras at the earlier stage of the CAR-T infusions, these are twice a day prophylactics, so they have to come back to our outpatients clinic, 1 in the morning, 1 at nighttime. So that's a little bit of tasking for patients and the family members, but we do use a low dose prophylactic. Adverse effects is injection sites reactions, headaches, vomiting, arthritis, pyorrhea, and nasopharyngitis. And some also for sub-Q injections for our patients, we reserve for the patients that have some platelets, so above 10 Ks. If they are lower than 10 Ks, then we will utilize the IV. For specific populations, so those patients that have a renal impairments that we wanted to make sure there's a creatinine clearance recommendations. Drug-drug interactions, if we are to utilize with TNF blockage agents, there's a higher risk for serious infections. And certain warnings or precautions that we want to look at is the serious infections, utilization with the TNF blockage agents, hypersensitivity reactions, and also neutrophil counts decreasing. So the next one is not necessarily a drugs, but is antibodies, IVIG. So as we mentioned, we want to make sure that we keep an eye on this patient's IVIG level to knowing that these patients are going to be a high risk for infection. So we want to utilize IVIG replacements at early on. IVIG is prepared from a pool of immunoglobulins antibodies from healthy donors' plasma. Using in our CAR-T therapy will be immunodeficiency states or secondary hypogammaglobulinemia. Rationale will be B-cell aplasias that the patients are expected consequences of on-target of tumor effects of the targeted CAR-T cells, leading to these low IgG and contributing to a risk of infections. Is generally we're giving these patients passive immunity by providing the antibodies. Right? Pre-treatment testing, we wanted to make sure that there's no evidence of viral infections, Coombs test or other clinically indicated testing before we give IVIGs. Doses generally will be, doses and products is depend on your facility's formulary, and routes we generally give it IV, although comes in subcutaneous as well. Administrations, we pre-med the medication, so maybe given 30 minutes prior to IVIG infusions with the H1 antihistamine, so your Benadryls, acetaminophen, and previously we talked about utilizing steroids. So generally, if I order IVIG, I do not order the hydrocortisone. And we just want to prehydrate them. So this is our order sets from our EPIC system. Generally, if I pull up IVIG, we will have this order set. And we also have these IVIG serum recheck in every 14 days. And I collect them because patients are not going to be in-house that long. I also will check Solicortef because we don't want to give pre-meds for it, but Benadryl and Tylenol will be given along with the hydrations. So dosage are weight-based and infusion rate, so they can have an infusion reaction. So we want to start slow and you can titrate up. Adverse effects, again, anaphylaxis or anaphylaxis-like reactions, although I have not seen many trali or tacos and headaches and migraines, but you want to be aware that these can happen and you manage together with your care teams and also transfusion medicine. Delay reactions can happen a few days and even late reactions, weeks and months after that, so you want to be aware of those. And other things that we want to look for is that IVIG transient effects on the lab tests. So especially what I looked at most importantly is beta-D-glucan for the detections of systemic aspergillosis, because we want to work up these patients for fungal infections and you want to send out these kind of markers, and the patient who had received the IVIG previously may have a false positive. So you want to be aware of these. And I think that's concludes my presentation. Thank you.